Annie, I think you're muted now.
Now, can you hear me? Bridget, are you there? Oh, it says I'm recording, but I'm sorry. I have to ask Bridget a question.
Hey, for some reason my audio is not
Well,
working.
listen, you're on speaker. Do I record to the computer or do I record to the cloud?
Record to the computer because the cloud will be way too slow.
That's all I need. Bye.
Yeah, it'll go to your downloads.
Okay, thank you.
I'll help you with it later.
All right, thank you. Bye-bye.
You're welcome. Bye.
Okay. All right, I'm ready to go, you all. I'm sorry I had to do that, but I didn't know what to do because I don't do it very often. All right, here we go. We're ready to start. I think we're ready to start now.
Yes.
It's something all right, Bridge. I think I can put you back on mute if you'll go back to mute for me, Bridge. Okay, you all. So, participants, how do I get this thing off there? All right, I'm going to put that down there. You cannot minimize when you are recording this event. All right, I won't minimize Zoom. All right, here we go. So, it's a mechanical ventilation. So, you and I breathe by a sucking device, but a mechanical ventilation.
Shared.
Pardon me?
Your screen isn't shared.
Just a second. Why couldn't we get going here today without any problems? But I have problems. My screen, here's this. Share my screen. Share screen 2. Okay, I won't do that. Is it shared now?
Yes.
Yes.
You can see, you can see me, which is the most important. Can you see the screen?
Yes.
Yes. Does it say it's recording?
Mm-hmm.
Yes.
Oh God, we're good. We are good. Okay. All right. We'll start again. So we breathe by sucking in, but a ventilator breathes by pushing. It pushes air into your lungs. All right. So it's a positive pressure device that maintains respirations for a prolonged period of time. How simple is that? How simple is that? Not very, but it is. So it does it a positive pressure, but we breathe by negative pressure. But this is positive. This is a pushing pressure. All right. So why do we use it? Why do we have to? It doesn't have to mean that they're not breathing. It could be because of apnea. It could be because they're not breathing. It could be simply because we're worried that they can't protect their airway. Maybe they're unresponsive. Maybe they have a big old distended abdomen and we're afraid that they're going to aspirate. Maybe we're going to do something that we're afraid they're going to aspirate. I know when we put down a great big oral gastric tube because of overdoses, it's called an EWALD. You're not going to be tested on that. It's called an EWALD EWALD tube. It's probably about yay big around, about as big as your esophagus would be. And we put those down. There's such a high chance of aspiration that before we do that for somebody that's unresponsive and they have a terrible overdose, we intubate them before we do that. Because we may need to protect their airway. So it doesn't have to be just because they're not breathing. There could be many reasons, but it could be because they're not breathing. It could also be because they're not breathing effectively, because they are in acute respiratory failure. Now, you learned this before in probably 152. It's not called 152 anymore, but in 152, I think for you all it was. Because they're in acute respiratory failure. What is acute respiratory failure? Now, you all are nurses. If I said acute respiratory failure to somebody in the public, they would probably say, oh, acute respiratory failure means you're not breathing. No, that's apnea. Acute respiratory failure means a PO2 below 60 with or without an increase in their PCO2. So meaning they are hypoxic. Acute respiratory failure means they are hypoxic. They may also be hypercapnic. Hypercapnic means an increase in your PCO2, but it doesn't have to be. So they're breathing. They are breathing, but they are hypoxic and it's not doing well. Okay. Or maybe they're just wearing out. Maybe they're having severe muscle fatigue and they are just wearing out. And we need to help them breathe. They're just not breathe. Their muscles are just giving out. And if we don't help them, they are going to have ineffective respirations. So I don't want you to think the only reason that we have to put people on a ventilator is because they're not breathing. It can be from lots of different causes. And here's some examples of some of them. So it could be like over in the right-hand column, cardiac and respiratory arrest, but it's not always. And they're not always respiratory in nature. It could be because of a coma, could be neurological in nature. It could be from noxious stimuli like carbon monoxide. It could be because you have a neuromuscular disorder. Jane will be talking about ALS when you all listen to your neuromuscular disorders, or Guillain-Barré, or we might be talking about head injuries may need it. So there's lots of, or congestive heart failure. It could be cardiac in nature. There's lots of reasons why people have to be put on a ventilator. So it's not just respiratory. It can be lots and lots and lots of different reasons. But the reasons are they cannot either maintain they're either not breathing, they're not maintaining their respirations adequately, or they're just wearing out, or we need to protect their airway, one or the other. There's lots of different reasons. Now, in order to put somebody on a ventilator, you have to use an airway adjunct. And there's lots of different kinds of airway adjuncts. But typically, to start out with, for an endotracheal tube, for a ventilator, we use an endotracheal tube. Now, I have some pictures of these too, but I want you to look at this one. I know it's hard. Okay, can everybody you all can kind of see that?
Are you showing us a picture?
Well, I will in just a minute. But I want you to look at this one. And then I want you to look at this one. So I'm going to put them side by side. Somebody tell me one of the differences that you see in this.
One is short. Get cuffed, like it gets blown up somehow.
Okay, one of them has this blue thing hanging. Here's another one. But here's another one. Okay.
It looks like they have different size lumens.
Okay, so one is the size. We'll start with the size. One of them is size. Well, obviously, we have pediatric would have a different size than an adult one would. So this would be a pediatric one. This would be an adult one. Now, both of these happen to have a cuff on them. But you can see on this one, there was no cuff. Okay, so size is one difference. And so they're pediatric, and as you get bigger, there's not just two, there's all different graduated sizes. And we measure them not by weight, we measure them by length of the body, okay? So that's one thing, is we have different sizes. The next thing is you're gonna notice some of them have this little dingly, hangly thing, and they call this a cuff, okay? Now, attached at the end of it, and I'm gonna do the big one because it's easier to see. Attached to the end of this is this, what they call a cuff or a balloon, right? Now, I'm gonna blow this up, and mine's been blown up a whole bunch. Usually this balloon will hold about, on an adult one, will hold about 10 cc's. So I have a 10 cc syringe here. You just simply plug it in, kind of like the end of a Foley would be. You got to kind of depress the little thing in there. And when you blow it up, it looks like a marshmallow, sort of. Okay. And so now this is tight like a marshmallow. Now, usually when I'm in the class, I have people compress this, and they can feel that this now has some oomph to it. Kind of, it is puffy also, because this little tube is connected to the marshmallow at the end. This is all one unit from here to here. So if this is puffy, if the blue is puffy, then you know the marshmallow at the end is puffy. If the blue is flat and not puffy, then you know the marshmallow at the end is flat and not puffy. Because once this is put down into my patient, I can't see the end. It's gone. So how would I know if the end was flat or if the end was puffy? I know because this part is not inside my patient. So if it's puffy, then I know the inside's puffy. If it's flat, I know the inside is flat. They call this the pilot balloon, okay? Or they'll call it a cuff, but this is really the cuff, but they'll call this the cuff because it's connected to the cuff. All right. Now, so I'm going to come back to this, but I think I've got a picture of this. All right, here we go. So this kind of shows, again, different sizes of the balloon and different, and some have cuffs and some don't have cuffs. So why, I need to move my picture so I can see this. So why do some have cuffs and some don't have cuffs? You only don't have a cuff on a pediatric one because, and I'm gonna go back to this next, I'm gonna go to this next picture. When pediatrics, when babies are born, oh, and that's B, look over here at B. When babies are born, their vocal cords are round. That's why babies cannot talk, okay? They are round and they can't phonate. They don't go in and out like adult vocal cords do, okay? And so when we talk across the lifespan, we talk about physiological changes across the lifespan. Pediatric vocal cords are round. And so when they insert this into a pediatric patient and they pass it through the vocal cords, the round cords give their own cuff. It makes its own round cuff around it, okay? However, at about 1 year of age, around 1 year, the vocal cords start to elongate out, which is what you see in picture A. And then the vocal cords start to move back and forth. And so it starts to allow them to phonate. And along with your lips, you start to make different kinds of sounds, high sounds, low sounds, different type of sounds. And this is about year 1 is when people start to talk. Now, when you try to blow into a balloon, Lynn, since I talked to you earlier, Lynn Wilson this morning, tell me what you do to blow into a balloon. You put a balloon into your mouth and what do you do?
You blow out.
Okay, but what do you do with the balloon in your mouth? What's important when you start to blow?
You want to seal
How do you seal it? What do you seal it with?
your lips.
Your lips. Can you have your lips around just open?
No.
No. If you left your lips open, it's much easier to blow out into this atmosphere out here. You meet much less resistance than trying to blow into a little tiny balloon where you have to blow pretty hard. Now, sometimes you even blow out right here and you end up hurting after blowing up balloons, you know? There's a lot of pressure to blow into a balloon than there is to blow out here into the air. Well, the same thing happens to the ventilator. It's much easier for that ventilator tube. Oh, shoot, I don't have one. You know, for the tubing of a ventilator to just blow out into the air than it is to blow into 2 lungs, 2 balloons. It's much, much easier. So what we have to do, well, so if I just put this in, if I just were to take this with, I lost my 10cc, so there it is. If I was to just take this and without blowing up this balloon, this cuff, if I was to just take this and insert this through the vocal cords and didn't have this up, as soon as they blew into the end of this and the air got to the very end of this endotracheal tube, even though it's through the vocal cords, it would blow at the end and say, oh, well, let's see, on down into these 2 balloons, there's a lot of resistance. I think I'll just go out the end of it and just blow right back out their mouth. So what they have to do, and I'm going to go to the next one, is you have to blow up the balloon. See, it's deflated up here into the trachea. They have to blow up the balloon so that when you blow air down the ET tube and air comes out the bottom, it wants to go back out their mouth because that's the area of least resistance, but it's blocked. The cuff blocks the trachea, so the air has nowhere to go but on down into the lungs. Every patient that is on a ventilator must at all times, 100% of the time, you don't hear us say 100% of the time very often, must have the cuff inflated 100% of the time. If not, the air will escape back out their trachea, back out their mouth, and the patient will not be ventilated. With the exception of the pediatric patient. That's because their vocal cords are round and they have their own physiologic cuff. The cuff must always be inflated. I think this next
Janie,
one-
just to recap, the pediatric patient that's going to be under 1 year of age, correct?
Yes. If they're getting close to one and they're having trouble maybe with a little bit of oxygenation, then you're going to have some patients that this is about the, even this one is smaller. But, they might have some that do have a cuff on pediatrics and some that don't. It's all depending on what they need for their patient. So right about one, some pediatrics have a cuff and some don't. It's all depending on if an uncuffed gets them oxygenated or not. And this slide actually shows them with one blown up. But even though I showed you one blow up, I have a slide showing you one blown up also. Okay, so 100% of the time, the cuff must be inflated. Typically, how much do you inflate it? On an adult, usually it's about 10 cc's. On a pediatric patient, it'll tell you it's usually very, very small, very, very small. Let's see what this one takes. It's usually less than 1 cc. It's a 1 cc. Actually, it took about a half cc to blow this balloon up, about a half cc. And they usually have a little small syringe in there that they use. It took about a half cc. Typically, you blow it up to the minimum amount that keeps the air from leaking. How do you know? When the air is blown in, there should be no sound that escapes out the patient's mouth. There is they can hook up a little device and listen. I never see anybody hook up a little, no wonder, see somebody ever blow that one's popped. But if they are leaking, if there's a cuff leak, if they're leaking air back around, quit stuttering. This is what you'll hear. The air will go in, you hear all you got to do is put a little bit more air in your cuff and that sound goes away. And that means now there's no air going around out of your trachea. So when they hear a sound come out, they need a little bit more air. Blow a little bit more air in there. Blow maybe a half a cc in there. Blow a cc in there or an ml and see if that sound goes away. And they'll know that. They know that sound. That sound should not be there when the machine gives a breath. This cuff is made on an adult, is made for 10 cc's. Mine was about 10. It's a little stretched out. It's been blown up a lot. Okay, so how do we put it in? They're put in by specially trained people. So you will not be putting these in. It's only by specially trained people. It can be put in by physicians. It can be put in by advanced care providers like PAs can put them in, nurse practitioners can put them in, especially trained paramedics can put them in, especially trained nurses can put them in, like the flight team nurses can put them in, respiratory therapists can put them in, and you may go to a hospital where especially trained registered nurses can put them in. It's all depending what falls within the policy of your institution, but you as beginning practitioners will not intubate. You in the preceptorship will not intubate. Okay, you will take care of patients post-intubation, but you will not intubate. When I first came to Carolinas Medical Center in 1981, if any of y'all are techs in the ER, you probably will drop over dead when you hear this because the ER was the exact same size that it is now, including the pediatric ER, but it was in a different place. We ran the entire emergency department with 1, 2, 3, 4, 5. We ran it with 6 nurses, and that includes E-hold, 6 nurses total for the entire ER, and 6 physicians total for the entire emergency department. But one of the things that the nurses did was we intubated. We sutured, we intubated, and we put in femoral lines. Because we were called mobile intensive care nurses. So I intubated a fair amount in the emergency department. Not all the time, but a fair amount. And did a lot of suturing, did a lot of femoral lines. But we don't do that now. We have plenty of physicians, we have plenty of nurses, and now we don't do that now. But you follow what is the policy of your institution. So if you're specially trained and your facility says you do it, then it can be a responsibility of specially trained nurses, but you will not do that as a beginning practitioner. So how do we put these in? Well, they can be put in either orally or nasally. Now you will probably see these put in mostly oral. Why? Because they're easier to put in and they are quicker to put in. You can use a larger tube, which makes it easier to suction, and the work of breathing will be decreased when you put them in orally. One of our nurses he was in a pretty significant car accident and was intubated post accident and had to be intubated for many days, ended up with a trach, and was very, very serious. And after he was better, he came back to work as a nurse. And I said to him, John, tell me about being intubated. I really am kind of interested for my students about being intubated. He said, take a McDonald's straw. He said, and plug your nose up. You can't breathe through your nose. And take a McDonald's straw and plug the side of your mouth up so that all you can breathe through is a McDonald's straw 24/7. He said, and that is what it's like to be intubated. He said, I know as a nurse, I knew that my blood gases were good. I knew that my pulse ox was good. He said, but I felt like I was smothering with each breath that I took. And he said, and it has to be McDonald's. He says, because McDonald's has great big straws. I said, oh, they do have big straws. But he said, it was just, he said, I just felt like I was smothering with each breath that I took. And so I always think about that when I think about my patients and how uncomfortable that it probably is. So also they can't close their mouth. And so they typically it's very uncomfortable, and their jaws are very uncomfortable. They get increased salivation. They usually have an oral gastric tube because we don't typically use nasal gastric. We typically use oral gastric tubes for them to decompress their stomach. They will often have a bite block in there. They have a lot of stuff stuck in their mouth. So it's difficult to do mouth care on these patients with increased salivation and poor mouth care. It will impair their gag. It'll impair their swallowing. So there's lots of problems with being intubated orally, but most patients are intubated orally because it's the easiest, and and you can use a larger tube when you do this. And I would say, if you all think about being techs in the ED, or how many times you see patients intubated in the ED, I would bet you would say that 99% of the time, patients are intubated orally in the emergency department. Because you can actually visualize the vocal cords, and the chances of missing your intubation is very decreased. So you're probably going to see that a lot. You can also put them in nasally. They're put in down through the nose, and they're passed through the vocal cords through the nose. They're much more comfortable. You can do better mouth care. There's nothing in their mouth. They're able to swallow. They don't eat, but they're able to swallow. But they're very, very difficult to perform. Who's ever put down a NG tube? Anybody that's willing to talk to me? Lynn, I talked to you. Lynn, you put down an NG tube?
That was me, Christy.
Christy, you put down an NG tube. Okay. Christy, when you put down your NG tube, did it go in the lungs?
It did not.
It did not. Okay. It did not go in the lungs. That's the answer I expected from you, Christy. Okay. So I want to know, Do you think the lungs have eyes? Do you think that looked up and it said, oh, look, there's an NG tube coming towards me. Send it over to the stomach as it goes through the nasal pharynx. But when an ET tube comes to me, oh, look, it's an ET tube. Close off and come on into the lungs. I mean, no, it doesn't. And your epiglottis or your glottic opening says, you know what? There's something coming down the nasopharynx, whether it's food, whether it's snot, whether it's a tube, whether it's blood, whatever it is, comes down and says, wait a minute. There's a safety mechanism here that says glottic opening shut. Don't let things come down into my lungs. That is not good. Go on down into the esophagus because the stomach can handle anything. It can handle alcohol. It can handle aspirin. It can handle anything. It can handle dirt. Doesn't matter. But the lungs, we can't handle that stuff too well. So you know what? Close off and don't let that tube in here. And what happens is that NG tube just slides right on down into the stomach at the bifurcation of the trachea and the esophagus. Well, when that ET tube comes down there, it says, no, 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 no. And it just slides right on down into the esophagus. Because it doesn't say, oh, NG tube, go that way. ET tube, come this way. No, it doesn't. It doesn't say that. So it's very difficult. It's a very difficult intubation. Usually done in the OR with the patient already very sedated, probably paralyzed, and they can actually watch it and force it down that way. So it's not an easy intubation. It's not as quick an intubation. Like when an emergency situation, when I got to go, you know, that kind of thing. So you won't see that many nasal intubations done, especially not on a quick basis, because they're hard. They're hard to do, and they're not as quick. They got to be more controlled. They do them a lot for surgery for people that are going to have massive mouth surgeries and stuff like that, where they don't want an ET tube stuck in there type thing. They can result in sinusitis. You usually have to use a smaller tube with smaller diameters. And so you have more mucus plugs, more difficulty suctioning them. So, you know, not as common. You're going to see many more oral endotracheal tubes than you are going to see nasal endotracheal tubes. It's the same tube. It still has to go past the vocal cords. You still have to blow up the balloon, the pilot balloon, and make the air go down instead of around it. But how it's put in is really up to the physician, the situation, but you're going to see oral tubes much more common than you're ever going to see nasal tubes. So what are some of the complications of intubation? What are we worried about? Well, number one is airway trauma. You can cause damage to the airway. Whether if you put it in nasal, you can knock out some turbinates. You can cause trauma to the airway. You can have trauma to the vocal cords. You know, I mean, you're going in. It's just like putting an NG tube down. You all have had bloody noses from patients when you put NG tubes down. You can have it with ET tubes. So you can always have airway trauma from that. Well, hypoxia. If it takes you a while to get it in there, the patient can become hypoxic, and that could be a problem. And you all know somebody sitting there counting down the pulse ox. They're at 90. They're at 88. They're at 87. They're at 80. About that time, everybody's butthole's going whoop. You know, that's called the butt pucker factor. And I often talk about the butt pucker factor. The butt pucker factor is when you're sitting there and your butthole goes whoop, and your eyes get big, and your face gets pale, and you get real hot, and you're going, whoa, this is not good. And you all will have a butt pucker factor if you haven't already. And the first time you have it, you're going to say, oh, Janie, I have now had my butt pucker factor. It's not a medical term you will find in a book, but you will have your butt pucker factor in your life. I've had many in my daytime. It's not a good thing. I've had it by myself, and I've had it with students. And I'm like, oh, this is not good. Okay, dysrhythmias. Your dysrhythmias are twofold. You see them because of hypoxia. The first dysrhythmia, the most common dysrhythmia associated with hypoxia is sinus tach. So your patient speeds their heart rate up. Why? They're trying to move more oxygen around. So your patient gets into a sinus tach situation. So, it's a normal sinus type of a rhythm, but it becomes fast. It becomes a heart rate between 100 and 150. Remember, all your rhythms are definitions. So you have a normal PR interval, you have a normal QRS interval, but your rate is between 100 and 150. And so that's your first rhythm we see due to hypoxia. If the myocardium becomes hypoxic, we typically see PVCs. All right, so Lauren Cafiro. Is that how you pronounce it?
Yeah, Cafaro.
If hypoxia is causing my problem, what would you do? What's the nurse going to do when your patient's hypoxic?
Are you giving oxygen?
Stop whatever you're doing and give them some oxygen. If it's during intubation, they're going to stop the intubation and they're going to, I don't have a mask. It would have a mask on it. Don't stick the ambu bag in the patient's mouth, okay? It would have a mask. But give them some 100, hook this to the wall. Make sure it's always hooked to the wall. I don't have any oxygen here. Hyperventilate them. If you're suctioning them, stop suctioning them and hyperventilate them with some 100% O2 because their problem is due to hypoxia. Now, the other dysrhythmia that we often see is due to vagal stimulation. And this could be, again, during intubation. And this would be also possibly during suctioning. It can also be during positioning. And so you're stimulating the vagus nerve. And when you stimulate the vagus nerve, see, this is all pathophys again. But what do we see in the patient? You get parasympathetic stimulation. Sympathetic stimulation is fight or flight. Parasympathetic slows them down. So when the vagus nerve is stimulated, you become bradycardic. Well, if I'm suctioning you, and it's not from hypoxia, it's from vagal stimulation, you become bradycardic. So Caitlin McCarrow, if I'm suctioning you and you become bradycardic, what would you think I would do as the nurse?
Give oxygen.
If I'm suctioning you and I'm stimulating your vagus nerve, what would I, and you become bradycardic?
Okay, I would stop suctioning.
Stop suctioning them. And giving them oxygen would be okay, but it's not due to hypoxia. It would be okay because they did become bradycardic and they probably could stand some oxygen, but it's tachycardia and PVCs that is oxygenation. Your cause was from the stimulation of suctioning them.
Yeah, that makes sense.
So stop suctioning them. It wasn't the hypoxia. Now, if you were suctioning them and they got tachycardic, stop suctioning them and give them the oxygen. What was causing it? That's pathophys, but you as the nurse had to say, what was causing it? Now, what do I do as the nurse? What do I do as the nurse? What do I do? If every time I turned them on their left side, they dropped their heart rate. Hang on, I got to get somebody else's picture up here. Jalecia, every time I turn them on their left side, their heart rate falls. What would you do, Jalecia?
I wouldn't turn them on the left side.
Get them off their left side, turn them back on their back.
Yes, ma'am.
Or maybe try to turn them again in 2 hours and maybe position them a little bit different. Get a wedge and turn them a little bit further or do something different. But don't just say, oh, too bad, it's left. It's time for your left side, sweetheart. You're going on your left. Well, what are you going to say? You're going on your left. Die, baby, die. You're not going to do that. Get them off their left side. Go back right, back right, back right. Let's try to position them a little bit different on their left. Okay, so is the problem hypoxia? Then I'm going to probably see sinus tach and PVCs. Is it vagal stimulation? Then I'm going to see a bradycardic situation because that's parasympathetic stimulation. That slows you down. Hypoxia is a sympathetic stimulation. That speeds you up. You learned that in A&P. Well, you You heard it in A&P. Let's put it that way. Don't know if you learned it or not. You heard it. Okay. Aspiration. Anybody that's being ventilated is at risk for aspiration because it can overflow, especially if you ever have to bag valve mask them before. So we typically, almost everyone that is intubated will have an NG tube or an OG tube down. I will tell you now that they may call them an NG tube, even if it's in their orogastric area. They will still say it is an NG tube, even if it is put down orally. So don't be surprised when they say they've got an NG in and then you go in there and it's in their mouth. That's very common. They're just saying they are decompressing the stomach. Okay. Somebody really didn't watch that tube go through the vocal cords. They got so excited and they just stuck it in. And instead of it going into the lungs or into the bronchus, they actually intubated the esophagus. So Demi, tell me, tell me some signs I would see in my patient that might tell me that my esophagus got intubated instead of my lungs.
Would you be coughing?
Probably not, because coughing would be something that would affect probably my lungs. So I don't think they would be coughing. So it's in the esophagus. So what?
Like escaping of air or you're hearing something?
Okay, where would I hear it? Okay, Demi, I like that answer. Where would I hear it?
Out of their mouth? Or
okay, I might hear it because it probably would be hard. Every time, I probably never would be able to get the balloon big enough. So I might hear that. Jenna Rogers, where else would I hear something odd?
Possibly in the stomach or in the bowels.
What would I hear in the stomach?
Air, gas.
Right. When I go listening for breath sounds, every time that machine gives a breath, I hear a sound in their belly. I'm hearing, quote unquote, that ventilator giving me a breath in their stomach. I don't hear breath sounds in their lungs. I hear breath sounds in their stomach. Jonathan Thompson, what else might happen if I'm blowing air in their stomach?
You'll probably see some abdominal distension. Like you'll see the belly rise and fall versus the chest.
Their belly's going to rise and fall. And then Jonathan also, and their belly's going to get bigger and bigger and bigger. Even though their NG tube might be down or OG tube might be in there, their belly's going to get bigger and bigger and bigger. Going to get distended. So you pay attention to that. Absolutely. I'm going to go down to cuff leak real quick. You can get that cuff leak, and I talked about that sound. Okay, that would tell you your cuff needs to be blown up a little bit more. And the last one is intubation of your right main stem bronchus. Now, you all, when you all draw a picture, or when you see a picture of your lungs, typically you see, y'all can see me, right? I can't see my picture because I've scanned down to you all. You see a trachea come down, and then there's a lung over here, and there's a lung over here. Well, that's not really how your lungs are in your body, okay? Your lungs typically, your heart's over here, okay? Typically, your lungs, you come down, and your right lung, your right main stem is sort of, it's not perfectly straight, but it sort of comes off right like this. And your right lung is like right here. And your left main stem, your left lung sort of goes like this. Because your
Janie, do you want to stand up so they can see you, or else tilt your camera down?
Wait a minute. Let me go so I can see myself. I just need to reset myself here. So if I see myself, here we go. Okay. Let me get my boobs up here. Okay, here we go. So your trachea comes down, all right? And your right, it doesn't go boom, boom. That is not how your lungs go, okay? You come down, and your right one comes down and sort of goes like this. And then you have a lung over here. I know that's a boob, but that's a lung, okay? Your left one sort of goes like this. And your heart sits right here. So it pushes your left main stem off to the left. So it's not boom, separate. It is one comes sort of this way, kind of straight, not perfectly straight, but kind of straight. And then this one kinks off this way. All right. And then your lung comes off of here. So they're sort of like this. Your lungs sort of sit in your chest and your bronchus sort of sits over like this. It sort of bifurcates like this, sort of sits like this when it bifurcates. So one sort of is kind of straight and one of them kind of sits off like this in your chest. So somebody that's all gung-ho is going to look down there and go, oh, I see them. I see the vocal cords. I see them. They're going to look in there and they're going to go whoosh. And they're going to slam the sucker in there and they're going to slam this really down far. And then they're going to get it in and they're going to get it past the bifurcation, blow up the balloon, and then be past the bifurcation. And they're only going to ventilate the right lung. This is my right, okay? They're only going to end up intubating the right main stem, and the left lung isn't going to get any air at all. That's called intubation of the right main stem. Okay, so when that happens,
Miss Janie,
yes,
is there not a way that you can, after intubation, where you can verify placement, like maybe through like CT or something?
Sure. I'm going to get right to that. Francine, let's go back to this first. I'll answer your question in just a minute. Francine,
Yes,
if this
ma'am.
happened,
Yeah.
what do you think you would see in your patient?
You would see, you would hear breath sounds on the right, but nothing on the left.
Exactly right. The left side's not being ventilated. The right side would be ventilated. So you'd only hear breath sounds on the right. Mackenzie Ball, what would you see? What would be happening in the chest? What would you see?
You would only see movement on the right side.
You would only see the right. They would both have to go because they're skin, but typically the right side would expand more than the left side would. It's not like the skin on the left, it's connected. It has to go up, okay, together. But you would see more rise on the right than you would on the left. Exactly right. So you're going to hear breath sounds on the right and not any on the left, and you would see more rise on the right than the left. And your patient would be very hypoxic because you've only got one lung being ventilated. So what do? We deflate the balloon, pull it back, reinflate the balloon when it's above the bifurcation. And now I got both of them going.
Hey, Janie, quick question.
Uh-huh.
For the intubated esophagus, would you also see hypoxia? Since
Oh, absolutely. Bad hypoxia.
yeah,
Bad hypoxia.
like would you even see that before you have a chance to see the abdomen distension? Is what I was wondering.
Yeah. Well, maybe.
Okay.
Maybe. It depending on how willing your doctor is to listen.
Okay, thank you.
This happened in PICU one time when I was on rounds. And they extubated a kid. The kid was about 10. And they re-intubated the kid, and the pulse ox was 0. And the kid looked terrible. And I said, do you have breath sounds with that? And the doc said, I'm in. I said, I don't think you're in. Do you have breath sounds with that? And the doc said, I'm in. I said, your pulse ox is 0. Do you have breath sounds with that? And about that time, their attending came in and they said, your pulse ox is 0. Do you have breath sounds with that? And the doc and the resident said, well, he sort of, now he's hesitating. And the attending said, pull it out and re-intubate. And he re-intubated. And then all of a sudden, the chest is rising and falling and the pulse oxes went up to 100. And I thought, you little jerk. You about let that kid die trying to be so special, but that type of thing. But yeah, you would see signs. Absolutely. Like no pulse ox. Okay. So these are some of the complications. Now, so what are some of we're going to talk in a minute about what's the nursing care. Someone was asking me, but give me just a second. So what are the other things that you can do? ETs are not, endotracheal tubes are not the only thing. You can also use tracheostomies. Okay. You can also use tracheostomies. Now, tracheostomies are inserted to the cricoid cartilage. I'm going to get my picture back up here so I can see myself. So I know when I'm using examples. Y'all can see what I can see what I'm doing. So you've got tracheostomies, and you know it's inserted through the cricoid ring. Now there's lots of different kinds of tracheostomies, but just like an endotracheal tube, if I don't have one that has a cuff, it will not work. They will blow air in it and it will come right out their stoma. So if it's being used with a ventilator, there must be a cuff that comes out around it. If they're not on a ventilator, we know we have plenty of patients with trachs that aren't on a ventilator because it can be used to manage secretions and to keep airways open. People that can't manage their own airway, like coma patients and stuff like that, but they're breathing. But if it's for ventilation on a ventilator, it must have a cuff. It must have a cuff.
Miss Janie, I have a question.
Sure.
Is there an exception for that with pediatrics, or is that only because with the ET tube it goes all the way down to the vocal cord?
Yeah, this is below the vocal cords. This is below the vocal cord, so that there is pediatrics will also have a cuff.
Okay, great, thanks.
Pediatrics will have a cuff. Yes.
So if it's not with mechanical ventilation, does it not have to have the cuff?
If it is without mechanical ventilation, it does not have to have a cuff. I'm going to talk about a little bit about that, but it does not have to have a cuff if it's not being used for mechanical ventilation. But if it is for mechanical ventilation, it must have a cuff.
Would you still have the ties on mechanical ventilation, or
you always have ties?
Okay.
Well, I said that very quickly, didn't I? I mean, there's probably people that have had a trach for 30 years that don't even have a trach. They just have a stoma.
Mm-hmm.
But if you have a trach in, you will always have ties.
Okay.
Always, 100% of the time, you will have a tie. If they have it, some people just have stomas, but if you have a trach, you will always have ties. Because the first time they cough, they'll just shoot it across the room.
Yeah.
Okay.
So if you get into a situation where you have to bag a patient that has an uncuffed trach, would you replace it with a cuffed trach in order to do that?
No, not necessarily. Not necessarily. You could bag around it. I mean, they might not get as much as if they had a cuff, but you could still give them some air. You could. All right, it will work both. And I'm going to do this and we'll take a break and then I'll come back and finish about like trachs that don't have a cuff. I do want to show you all that it can work with a non-disposable trach, and you all haven't seen a lot of these, but this is a non-disposable trach. In other words, you have to take this out, clean this, and then put this back, and you can hook the ventilator to that. Or most of you all have dealt with a disposable trach that looks like this, where you depress the little wings. And this won't fit in this. This cannula is too big for this trach. These aren't interchangeable anyway. This has to go into a base that's for a disposable trach. And these are the ones that you throw away and you pick up a brand new one and slide it back in. But I do want to show you this. When you look at an ambu bag, and this is actually an ambu bag. When you look at the side of this, it actually says ambu. Okay, this is actually an ambu bag. But when you look at a bag valve mask, the connector on a bag valve mask is universal. They're all the same size. So it will work for an adult endotracheal tube. It will work on a pediatric. This is the exact same connector. It will work on a non-disposable trach. It will work on a disposable trach. Here's a neonatal ambu bag, an adult trach, even though we wouldn't use it. These are all universally adapted. They will always fit. So you don't say, oh my gosh, I got to go find the right adapted. They all are universally adapted. Well, I pulled the thing off. Okay, so they are always universally adapted. When you use an ambu bag, you always must connect this to the oxygen source. Okay, because there's only 21% oxygen in the room, so they need a higher oxygen source. Okay, it's 10 o'clock. I'm gonna see y'all back here at 10 minutes after 10 so that we can finish with this. And I'm gonna talk about the rest of this about trachs, and then we're gonna go into other kinds of airways. All right, I'll see y'all at 10 minutes after 10. All right.
Like there, Mackenzie was talking about how like they hit the carotid, and is it like with pediatric patients, because they have smaller airways, is there like likely that there's more like complications that you can hurt them in different ways like that? Is that why?
Well, I can't speak. People that know how to deal with pediatric patients classically do not have as many, they don't have any complications either. They do.
Okay. Gotcha.
I think that was probably just an unfortunate situation.
Okay, gotcha.
More than I've seen plenty of kids that there were absolutely no complications with this. Before they had a pediatric ER, we did kids constantly in our ER, and I did thousands of pediatric airways, and we rarely had any issues, if any. So I think it was an unfortunate situation. Okay, so cuff must be used for any ventilators, must be used. They'll often use cuff when someone goes down for a new trach, even if they're not going to be on a ventilator. Because I want you to think about when you all suck in a little tiny, when something goes down the wrong way and you get strangled. Now, Jane Benetti thinks that's the funniest word, strangled. You know, when I got strangled, she goes, strangled. Maybe because she's from Boston and the Boston Strangler. I don't know. I made that up. But she thinks that's a funny word. But I said, you know, but you think about this tiny little bit of water or Coke or whatever that went down the wrong way and how it causes a bronchospasm. You know, you start coughing, 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 coughing. Imagine when this thing is touching your trachea, when you're not used to it. So what they do is they put in a new one, and when you just get in your first trach, and they blow up the balloon so that it's not wiggling around. So you come back and you think, well, isn't the balloon irritating? Not as much when it's just there. Then if it's there and not there, there and not there, there and not there. So they come back and they'll have their balloon blown up. And then it sort of gets desensitized to it. And then they'll start decreasing the balloon. So typically when they come back with a new trach, the balloon will be blown up. Now, I'm not talking about ventilator now. I'm talking about just getting a new trach, okay? And then they'll take the balloon down. And then as they get more sensitized to being touched and not causing a bronchospasm, they might have one that doesn't have a cuff if they're not on a vent. Also, they're not really sure how to eat with the trach in. Again, I'm not talking ventilators here. And so typically when they start to feed themselves, they will blow the balloon up when they start to eat or start on clear liquids. Because what happens is you and I, we start to eat, we hold our breath. It's a reflex. We hold our breath when we swallow, and then after we swallow, we breathe. But they're breathing here, and they can't coordinate swallow with breathing, because it doesn't work. They don't have that reflex there because of the pressure on the back of their tongue says hold their breath, but they can't hold their breath. And so they have some issues. So they tend to aspirate a little bit more. So typically when they start to eat, we'll blow their balloon up at first and we'll start them on clear liquids, and then they won't aspirate. And then little by little, we start to decrease their feeding, not their feeding, excuse me. We start to decrease their balloon so that they don't aspirate as much. Now, if you blow up the balloon really, really tight and they say, I feel like I'm having difficulty swallowing, then let their balloon down some, because you probably are compressing their esophagus some and they're having difficulty swallowing because you've got the balloon blown up too much. So that's what the positive and negative is. They may be able to eat better with the balloon up at first, but if you've got it too tight, they may find that they're having difficulty swallowing, then let the balloon down some. But typically they'll learn quickly and you can start letting the balloon down. Now, fenestrated trachs are a special kind of trach, and it's ones that have holes in them in this part of it. And you turn these and it kind of opens it and closes it, because that's what fenestrated means. It means holes. Like when you all go to get stitches and there's a drape that has a hole in it that they're putting the stitches, they put the cut through, that's called a fenestrated drape. And so that's what a fenestrated is. So a fenestrated trach are ones that have holes in them, and they make the holes smaller and smaller, and then, or really larger and larger, if you want to know the truth. And they start to breathe through the holes instead of through this hole right here. And so fenestrated is usually used for weaning, when we're trying to wean people from this. So, but a trach is a way that we can also use an adjunct to a ventilator, usually for long-term ventilation. There are other airway adjuncts not used for ventilators, but there are airway adjuncts. The first one are oral, and I have some here, but I also have them on a picture, and I'll go through there. You all have it. So here's some on a picture, but I have some. But this shows that they do come in multiple sizes. And you can see I have big ones here, and I have them all the way to this little tiny baby one right here. Okay. So they're all different sizes. And you measure them. It shows a great picture of measuring right here. You measure them up from the tip of the patient's mouth to the angle of their jaw. If it goes down past the angle of their jaw, it is too big. If it's shorter than the angle of their jaw, it's too small. If it's longer than the angle of their jaw, it's going to occlude their airway inside of their mouth. If it's shorter, it's not going to pull the tongue away from their oropharynx and open their airway. So this one is fitting perfectly. So this is the way that you measure outside their body to know which one is the appropriate one when you go and go to measure it on your patient. Now, these are very, very stiff. I can't really bend this one at all. Okay, it's very, very stiff. They are put in by a tongue depressor. You depress their tongue and you put it straight in. If you're working with an old person, you may see them put them in upside down and then twist them and slide them in. That is not the correct way. Years ago, 20 years ago, that was the way they recommended you put them in, but it causes a lot of airway trauma, and that is not the correct way of putting them in. Now you simply depress the tongue with the tongue depressor and slide them in until it hits the mouth. That is the correct way of putting them in. These will can only be used on people that are unconscious. It will cause a gag. So the unconscious patient that does not have a gag reflex are the only ones that can use these. Once they start coming to, they have to spit these out because they will start to gag and sputter on you. So these are only for people that are unconscious and do not have a gag reflex. All right. Now, the other one is a nasopharyngeal airway. Again, they come in lots of different sizes depending on your patient. You measure them different for adults than you do for children. You go from the nose and to the opening or to the bottom of the ear or right at the ear, and you do it this way for adults and upside down for children, and you go to the little trachus of the ear there, tragus of the ear. I said trachus, but it's tragus of the ear. So it is a very flexible type of device. It's put in, some people call it a nasal trumpet, but it's called a nasopharyngeal, and it sits into the nasopharynx. And so it does not cause a gag reflex. So it can be used both on unconscious and conscious patients. Nurses do put these in. Nurses put both of these in. When you put these in, you lubricate this with a water soluble lubricant like KY jelly. And then when you look at the bevel, and the bevel on this one at the top is the little part that's facing you, this green, this part right here. And on this part, you can see it's this sliding part right here. This is the bevel, like the bevel of a needle, this part right here. After you lube this up, the bevel must be inserted toward the septum. So if you're putting it in on the right side, you're going to insert so that the bevel, if I can get close enough, is going to go toward the septum. It's going to go in this way. All right. And you would just lube it up and slide it right on in like an NG tube would. Okay. But if you're going to put it in the left near, see my bevel, it doesn't go out laterally. It has to go toward the septum. So you're going to put it in upside down, like almost like an elephant. And as soon as it gets to the back of the nose, then you can turn it and it will slide right on down. And believe me, it will. Your turbinates sit right about right here. Okay, they're back in your nose, but they sit here. If you put this on the outside, as it goes past the turbinates, it will rip them out. And they will have a horrendously, it hurts, number one, and their nose will bleed and bleed and bleed and bleed and bleed. So you need to put them in correctly. And so you do that by always inserting them in toward the bevel, toward the septum. Again, this can be used on conscious patients. It will not stimulate a gag reflex. Very, very flexible, very, very comfortable for the patient. So one is an oral airway, only for unconscious. One can be used for conscious or unconscious patients. These are great for like little old people that can't cough up stuff. You can put these in and then put a suction catheter back there and go suck down the back of their throat and get that stuff up out of there. It's great. And then it doesn't cause them to gag.
Janie, are these just open to air, or do you hook them up to oxygen?
Yeah, they're open to air. They're open to air. Mm-hmm.
Janie, I work part-time as well, like not just at the hospital, but at a plastic surgeon's office. And they actually use these a lot for when they come out of surgery and they're not like breathing well enough on their own and they can't be intubated anymore. So they stick these up and people wake up and they're like, what's in my nose?
Right, exactly.
But they're pretty good.
And if you work up at university and they do a lot of the, I don't know what the procedure's called, but where they break the jaw and they bring for people to have the underbite and they bring that jaw forward. They do a lot of that up at university. Dr. Matthews, the plastic surgeon, does those, and all those kids wake up, or it could be an adult too. They wake up with the 2 nasal trumpets in, almost always. Yeah, always. Okay, pretty standard. Somebody should have told them they were going to have it. Okay, so elective paralysis. Now, elective paralysis also can be called rapid sequence intubation, RSI. You might hear it called that. And so what this is this is a chemical paralysis. And this is temporary. It is temporary. But this is a chemical paralysis used to either assist with intubation or used for ventilator control. It is to chemically paralyze a patient. Now, in the ED, we often will use it just to intubate them so that everything is just paralyzed, everything is completely relaxed. And as soon as we get them intubated, we let it wear off and they wake back up. But in the ICU, they may keep them out paralyzed for days and days. It's all based upon what the client needs. So some of the ones you may have heard of are succinylcholine is one, for example. You may have heard of Pavulon or Norcuron. Those are very common ones that are used. Those are probably your most common ones that are used. Now, these are neuromuscular blocking agents. These completely these completely stop any movement at the synapses. They're neuromuscular blocking agents, and these patients cannot move anything. The only thing that works is their heart, because your heart has automaticity. And so your heart does not stop, but your eyelids don't blink, your gut works, but your lungs do not work. You can't move your arms, you can't move anything. So you are completely paralyzed. However, it does not stop your neurosystem. And so it stops your motor system, but not your sensory system. And so you can feel, you can hear. If I lifted your eyelids, you could see. I guess you could taste. So, but you can't move. I could take a scalpel and perform surgery on you, and you would feel every cut of that scalpel, but you could not tell me that you could feel it. And they do use this during surgery, okay? So, it is always used in conjunction, always, and always is a hard word. You don't hear that too often. It is always used in conjunction with a sedative. We give the sedative first. We put them to sleep with a sedative. They go to la-la land, and then we paralyze them. So it's not like they're all of a sudden going, I can't breathe, I can't see, I can't move. Oh my God, I'm done. Oh, you're sticking me. Oh, you're hurting me. Oh, no, we put them to sleep first, and then we paralyze them. Some sedatives you probably maybe heard of are Versed, which is midazolam. That's the generic for Versed, midazolam. You may have heard of propofol. That was what Michael Jackson liked really well, unfortunately a little bit too well. You may have heard of etomidate. We use etomidate a lot in the ER because the half-life is very short. So they wake up pretty quickly. We can use the barbs like phenobarb, pentabarb. We can use the barbs. They're a little longer acting. We don't typically use those. I'm trying to think of, come on, ICU people. I know it as well as I know my own name. What do they use?
Fentanyl?
Well, fentanyl is an opioid, and they use that more for pain than they do for sedation. But they do use fentanyl, but it's not the one I'm trying to think. Oh, Precedex. That's what I'm thinking of. Precedex. I just couldn't think of it. Precedex they call it Dex. Precedex is used a lot, okay, for sedation. I just couldn't think of it.
Hey, Janie.
Yes.
Real quick, my dad has been in the hospital. He just got off his ventilator and stuff. He's had COVID, and like he was on pretty much every single sedative you just mentioned at one time because he got so used to all of them. But he was like on the max dose of every single sedative and paralytic that they could have used on him. But they're powerful drugs. It was just really interesting to see how that all worked for him. And to understand what he still remembers from everything.
Well, the one that has the most amnesic effect is midazolam, is Versed. Versed is a benzodiazepine, but it also has a great amnesic effect. So they don't tend to remember as much when they're on midazolam.
Janie?
Yes?
What is rocuronium for?
That is your neuromuscular blocking agent. That's not a sedative. That's the one that paralyzes them, but it is very long-term. So I don't know the exact half-life of that, but it's hours and hours and hours of half-life. Where the half-life of succinylcholine, they call that Sux, is like 15 minutes, 20 minutes. So in the ER, they'll give it to you, they'll intubate you and let your paralytic wear back off. So remember, these patients, we may paralyze them, but they need to be sedated first so that we put them to sleep. But once they're paralyzed, you really don't know if they can hear you. You think you've got them sedated well, but you got to remember, these patients, their senses are intact. So we always got to remember, they might hear you. They can feel you. They can Here, they could see if their eyelid was to pop open, that type of thing. So just remember, their senses are intact. That's very important. So don't be talking or saying things you wouldn't want to say in front of them. Okay. So what are the types of ventilators? There's lots of different kinds of ventilators. The first one is a hand ventilator. Looks like this. This is a hand ventilator. It's called a bag valve mask. We often call them an Ambu bag, but Ambu is a brand, okay? Like Kleenex is a brand of tissue, but everybody knows what you're talking about when you say Ambu. It can deliver any % of oxygen at any rate I want to give. It has a lot of advantages. I can watch your chest rise and fall. I can feel how much pressure I have to give a breath. I'm standing next to the patient. It's one-on-one. I know they're good. They're working down there. Your foot looks good. It looks nice and pink. It was kind of blue when it came in, but your foot's looking really pink right now. I mean, the patient's getting nice contact with somebody up there. The problem is it's one-on-one. While I'm up here, I can't be with anybody else. Plus, sometimes I might be fast. Sometimes, I'm sorry. It can be very inconsistent. Some breaths can be deep, some breaths will be shallow. So it's definitely for short-term use. It's a nice thing, but it's for short-term use, no question. But this is a type of ventilator that you could deal with. Now, a pressure cycled ventilator is set to give a certain amount of gas, a certain amount of volume, a certain amount of air until it meets a dialed in amount of pressure. Once it delivers that much pressure, it stops pushing. It's positive pressure, and it will push until it meets resistance, that much resistance. The problem is, it could be because it fills the lungs, and that's the pressure it met. But what if I'm doing this? And it meets pressure right here. My lungs never got ventilated because it continually met pressure from me biting the tube. Or what if every time it started to give a breath, I coughed out at the same time that it was trying to breathe in. And so it's cut off because it met the pressure. Or maybe every time it turned me on one side, at the end of this tube, there's only two little openings. There's a big opening at the very end. There's an opening right here. And there's a little tiny hole right here. Well, what if every time they turn me over, it plugs up one of these holes? Well, then it's going to have more pressure. It's easier to push through two holes than it is to push through one hole. And so anything that increases the pressure is going to make that machine cut off quicker. Anything, so your lungs could get stiffer, they could fill up with water, they could fill up with pus. You could bite the tube, the position of the head. There could be water in the tubing. Anything that caused the narrowing of the tubing could increase your pressure. So we don't use these too much for ventilators. You may have heard of them before. We use them sometimes in the rooms to give breathing treatments called intermittent positive pressure breathing machines, IPPB machines. And you may have seen them. They're usually little white boxes on rollers. They could be vents. If we were to get out of vents and we needed one in emergency situations, maybe even some COVID patients, maybe. We could use IPPB machines. They're not our best, but we could use them if we had to. But anything that's going to affect pressure, it's going to affect us. So we usually use them for like giving breathing treatments for people that maybe don't take good handheld nebs, but we could push it in with a little bit of pressure. Okay, so those are IPPB. So we don't use those too much. Now, a volume cycled vent is set to deliver a certain amount of volume, no matter how much pressure it takes. So you tell me what tidal volume the patient has in their lungs, and we will deliver that much volume. Now, this is the type of ventilator that we use in the hospital on most adults. This is the MA2s. These are the volume ventilators that are used in the hospital setting on adults. We will deliver this preset amount of gas meaning volume, meaning air, oxygen, pressure, gas being delivered by pushing a bellows. This is until no matter how much pressure is required. This is the normal ventilator that we have. Okay.
Question. Hi, it's Lemon. I have a question. So does that mean like you already have it set on the type of volume you want and it's just given consistently no matter what type of pressure?
That is correct. That is correct. We're going to go through that in just a second, but that is correct. Okay. Now, yes, it's going to give that pressure, but there are 2 alarms you are expected to know for me and for NCLEX. Okay. And one is the high pressure alarm, and the low pressure alarm. Oh, those are 2 difficult ones, aren't they? The high pressure and the low pressure alarm. The high pressure alarm says, you know what? I gave the tidal volume that you told me to give. You dialed it in the machine. I gave it. But you know what? It took more pressure than I think it should have taken. There's something that is occluding the tube. There's something that's making me to have to deliver more pressure than I think that it should. So come over here, nurse, and check, or respiratory therapist or whoever, and check this patient. There's something that's making the pressure too high. I gave it, but there's something wrong. Come and check it. The most common thing is or are secretions in the lungs. You come over, you listen, sure enough, tons of crackles. You look down and there's snot and secretions and all this stuff in the tube. And so who am I on? I don't know who I'm on. Helen, you there, Helen Smith?
Sorry, I was on mute. Yes.
Helen, when there's all these secretions in the lungs, what would you as the nurse do?
I would suction or move the patient.
What was the second thing you said? I just didn't hear you.
Move the patient.
Well, you might turn them, but you know what? I would suction them. You're exactly right. If I listened and their breath sounded terrible and their cough got all this yuck in their tube, and they're in their I look and there's all this junk in their tube, suction them.
Mm-hmm.
And you know what? Now I'm not having to blow past snot and yuck. I suctioned it all out, and now the tube is clear. And you know what? The high pressure alarm went away. Okay, maybe they're biting on it. Diamond, they're biting on it. What would you do?
Take it out their mouth, like try to get them to stop biting on it.
Take what out of their mouth?
The actual like the actual ventilator, trying to like move it out of their mouth and back to where it
Well,
needs to
you might be able to move it. You're not going to take it out. If you took it out, they would probably they wouldn't have any way to breathe. So that wouldn't be the most therapeutic thing to do. So how would you
can move the tube like more in their mouth?
Well, you might change the position in their mouth, and we can move them within their mouth, but they're biting pretty hard. So Cassie, what do you think we would do for people that are biting on their tube?
Could you put in a bite block?
We might put in a bite block, and they make bite blocks, or they might even use this if they're unconscious, especially, or a bite block. Some of them are smaller, but some of these, you'll find these in people's mouths so that they can't bite down on their tube because it's hard. So we put in a bite block on these patients, and then they'll bite on the bite block instead of biting on this little flexible tube. Very good. So maybe they're biting on it, okay? If they're coughing against the tube, every time it tries to give a thing in, or they're coughing out, or they're very, very restless and they won't let the machine give them a breath, we sit there and we call that bucking the ventilator. And you'll find they're you can't hear a cough because going through the vocal cords is what makes your noise. So you can't hear a cough, and they'll, like typically when they're coughing and they won't let the machine, it might be the suctioning will clear up the coughing, maybe. But if they're fighting it, if they're trying to breathe out when the machine's trying to give a breath and your pulse ox is dropping because they're not getting a breath, typically the treatment for that, if they're bucking the ventilator, is give them some sedation. They need more sedation. They're not letting the machine do the work that they need to do. You might need to turn up their sedation a little bit. There can be other kinks. Maybe you accidentally caught the kink, the corrugated tubing coming out of the machine. Maybe you caught it in the side rail and didn't realize you caught it in the side rail. Walk yourself back to the machine. Maybe there's a kink in the tube and you didn't realize you caught it under the patient's leg or something and it was kinked and you didn't realize it or something like that. So make sure that the tubing is nice and straight. And you won't see a lot of water like we used to see, but have you all ever seen if you've ever had a patient with a trach, there's a little bag that has water hanging in it off of that corrugated tubing. Has anybody ever seen that? Yes? Yes? No?
I have.
Yeah,
Quite often, it used to be that water would collect in that Ripley tubing, but now they hang it off that tubing, and that is just water that drains out of that tubing so that it doesn't collect, so that when you turn the patient, you don't drown them and send it down into their trach. And that water, if you empty that bag, you can just put that in the trash. Just open it up and pour it in the trash. It doesn't count in your I&O or anything. But sometimes if you don't have that bag on there and there gets a lot of water in that corrugated tubing, well, the lumen narrows, and so you can get more resistance. So if there's water in the tubing, that's what they mean by water. A lot of water, and not in your ET tube, but in that Ripley tubing that goes from the ET tube back to the machine. There shouldn't be a lot of water, and usually there's a bag in there, and water collects in that. Just empty it. Respiratory will usually take care of it, but sometimes it doesn't. The low pressure alarm says, I gave this, but it didn't, I didn't meet much resistance. I don't feel like I blew into the lungs. I blew somewhere else because the lungs should take this much pressure and I didn't have to blow that much pressure. It usually means you did not ventilate the lungs. So come over and look at it. If they have a trach, if they pop off the trach, then you know what? Put them back on the trach. That's real common. Maybe they coughed and they popped themselves off. If it's an ET tube, your worst case scenario is you go in there and the ET tube is sitting over here on the bed and the patient's has extubated themselves. Caitlin Smith, if your patient extubated themselves, what would you do?
I would first inform the either respiratory therapist or doctor and maybe do like supplemental oxygen.
That would not be the first thing you would do.
No.
Your first thing is always for your patient. It is not to go notify somebody. Your first thing is always to care for your patient, okay?
Mm-hmm.
So I would look at my patient and I would say, well, how are they? What's their pulse ox? Are they okay? If they're okay, then I might say, okay, let's put some O's on them. Let's give them some supplemental oxygen. If they're not okay, Mackenzie Ball, what would you do?
I would start bagging them.
You get your bag valve mask out. And that is why, and you'll see nurses do this all the time. When you intubate a patient, they'll pull the mask off, they'll throw the mask in the trash, and then they'll start bagging them. Do not throw your mask in the trash. You tape it to the head of the patient's bed, because if they extubate themselves, you kind of want that mask so that you can bag their face. Because if not, you're going to look at that and go, well, I can't do this. How am I going to ventilate this patient? I'm in trouble. You want to be able to pull that mask off, stick it onto your bag, because 99% of the time when they're intubated, you're going to use this to bag them. But you need that mask in case they extubate themselves. Okay? And in that corrugated tubing, there's a lot of little connectors. There's little tiny wires. They might be a temperature gauge. It might be a water gauge. And if they pop off, you'll hear this sound. And if you hear that, you say, oh, there's something loose. Oh, here's the wire. Here's the wire. Here, let me just put it all back together. But sometimes those little things pop off. Okay, so that is the 2 alarms you're expected to know, a high pressure and a low pressure. And what does the nurse do about them? If I gave you a scenario, what would you do? I'm not going to ask what is a high pressure alarm, what is a low pressure alarm, but this is what happens. What would you do as the nurse? Okay.
Amy, what would so the first thing you would do for high pressure, would that be
Well,
like,
it depends on, probably go suction them. That's the #1 cause of a high pressure alarm. They need to be suctioned.
okay.
I don't know. I don't know what the test question is. I didn't write the test. Jane did. I'd have to look at it.
I have a question.
Yes.
So you know how you said when they're bucking or coughing and you may give them a sedative, could you also give them a paralytic as well?
You could give them a paralytic, but you have to give them a sedative before you give them a paralytic.
Right.
Always. You could. Yeah, they wouldn't be able to, they would not be coughing if they're on a paralytic. They would not, because they couldn't cough if they were on a paralytic. They're completely paralyzed, so they can't cough.
Miss Janie.
Yes.
So we would just be assuming that these orders kind of will already be, the patient will already be ordered these things, so we would just give them. It's not something that we're doing without orders.
Oh, you mean like the sedative or the paralytic?
Yeah, and then.
Oh,
and
yeah,
then
you will have an order
oxygen.
for those. You'll have standing orders for those, yes.
Okay.
Because they're going to be in an ICU, so you're going to have standing orders for those, yes. There are 2 other kinds of ventilators. They're very special, and they're not ones that you're going to see on NCLEX by any means. But just to let you know, there are other kinds of ventilators. One is a time-cycled ventilator. Time says, I will deliver a preset amount of gas for a certain amount of time. And this is typically what you see in the NICU. And they're just little psst type ventilators. They just spit in them, just psst, psst, psst. They're very short time cycled ventilators. Again, very specialized ventilators. And the last one are oscillating ventilators. And these deliver a very small, rapid respiratory rate, usually 100 to 300 breaths per minute. And so their purpose is to make sure to keep all the alveoli open so that the gas exchange is taking place in all your alveoli. Because usually about 10 to 15% of your alveoli are closed with each breath. So they want them all open. So gas exchange can take place with all of them. Oscillating ventilators are used for people that are in severe acute respiratory distress, which we're going to, acute respiratory failure, which we are going to talk about first this afternoon. So we used to, at one point we went through a lot of oscillating ventilators, and then we went through not so many, and now you'll see them occasionally, but not too much, not a whole lot, not so a whole lot. I'm gonna skip this for just a second. I'm gonna come back when this ventilator mode takes way too much time, so I'm gonna do it first thing after lunch. All right, but I do have 2 minutes, so I just want to talk about this. As far as ventilator criteria, not everybody can take care of ventilators. You should have attended special classes. They will be in an ICU or on a special unit that allows ventilators. So you won't just be on a unit and all of a sudden you'll have a ventilated patient. It will take a trained personnel. They will have to be intubated or have a special airway adjunct like a trach with a balloon, because as you know, they have to have an airway adjunct. The doctor will order what rate the settings, and we're going to talk about rates and settings when we come back from lunch with the modes. As a nurse, you are to check breath sounds frequently, every 2 hours or with any position change. And so your job is to make sure that you're getting good breath sounds with the ventilator. So you're to be checking that patient. And when a patient has a ventilatory change, when they change the settings, ABG should always be done about 30 minutes afterwards, and you should check them. If you're working in a specialty unit, you should not rely on respiratory only. You work as a team. And if well, I'll quit stuttering. I used to say to my respiratory therapist, I've checked this, and you changed the rate, or you changed the FiO2, or you changed something. why did we change this? What's going on? I really want you to tell me when you make a change. You know, I need to know, this is my patient. I should know when there's a ventilatory change. And why did we change it? What changed in my patient that required a ventilatory change? So always be part of the team. If your patient's on a ventilator, you need to be part of that team. All right, y'all, it's 10:50. I will see you all back here at 12. And we're going to finish up with ventilators, and we're going to talk about acute respiratory failure, PEs, and ARDS after lunch. All right, I will see you all at noon. I'll be here for a second if anybody has any questions. Yes.
Thank you.
Was there a question? I thought somebody was going to ask me something.
Yeah, Miss Janie, I had a question.
Yes.
When you're talking about like pressure and resistance, are you using those like interchangeably?
No, pressure is what's, well, I sort of am, but I'm really not, but I am. Because resistance, pressure is the amount that you have to push in. Resistance is what the pressure is meeting. So if you increase resistance, then it's going to take more pressure.
Okay, I gotcha.
So I sort of said that they're kind of the same, but one is on one side and one is on the other, but one goes up, the other one's going to go up.
Okay, gotcha.
Janie, I had a quick question too. The water in the tubing, is that coming from like humidified air?
Well, humidified water, but yes, because remember that your nose and your oropharynx and your nasopharynx is how we humidify our respiratory system. And when you have an endotracheal tube or a trach, you bypass your oral and your nasal pharynx. So any air or going into your respiratory system is not humidified. So we have to provide that patient with humidification. If not, they will become very thick and sticky and white. And so we have to provide that humidification, or they will.
I just didn't know if that's where the water was coming from in the tubing.
Yeah, it's not coming from the patient. It's coming from the machine into the patient.
Thank you.
Yeah.
Last quick question. As far as the MD orders for like the drugs that you give, I know like in the ICU and ED, you can titrate, but is there like on orders, are they going to give you what you can titrate up to based upon weight or what have you?
Well, that's individualized.
Okay. I didn't know if there was like a broad standard.
Well, there are safe dosages. There are safe dosages. On certain drugs, you cannot go above that dose. I mean, it's kind of a known thing, and you'll get onto the pump and it will say, you know, you cannot go above this limit. That's not allowed. And then there's going to be ones that say, like Levophed, for example, we do not recommend that you go above, oh God, what is Levophed? Is it 30 or 30 mics per kilo or something? I think it's 30. It could be 40. We don't recommend that you go above 30 mics per kilo, but we do go above 30 mics per kilo on patients all the time, because if we don't, they're going to die. But we do know that if we go above 30, they're probably going to get their feet and their hands amputated. I mean, you know, but we know that this is considered the highest, but we know that we do go above that. So as is always, even though we like to have black and white answers, there is no black and white answer. There's going to be what's considered safe doses, and then there's going to be ones that are considered, these are outside what's considered safe, but we realize that these are doses that we may have to give.
Thank you.
I know some of y'all have to go to lunch, but I say that on the Levophed because my mother, my brother is an engineer, and I don't know what you know about engineers, but engineers are very black and white people, very, very black and white. And when my mother was in the ICU over at Mercy, you know, these smart pumps, they say as it goes across it, you know, they're on heparin at so many units an hour, and they're on this at so many units an hour, and she was on Levophed. And of course, my brother gets out his smartphone and he looks up, and the Levophed, you know, is supposed to, she's on way over the normal dose of Levophed, way over the normal dose. And he says, wait a minute, it says the normal dose is 30 mics or 20, whatever it was. I really don't know what the normal dose of Levophed is, because to me, the normal dose is whatever the patient needs. And so, and he says, I want her turned down to the maximum dose of Levophed. And they, I said, Ernie, you can't do that. As if we turn her down, she'll die. Is that what you want? That she'll die? And he says, well, no, I said, we can start weaning her down. If that's what you want, we can wean her down. And I knew we were going to have to discontinue. I mean, I knew she was going to die. He wasn't ready yet, but I knew what the outcome was going to be. There was no way. She was in multi-system organ failure. I knew what the outcome was going to be, but he wasn't ready yet. And I said, we can start turning it down, but you can't drop from, 55 mics to 30 mics immediately. You got to wean it down. And he could not stand it. He could not stand that she was over what the maximum dose was. And so they started turning her down little by little, titrating her down. And when she got to whatever the maximum dose of Levophed is, he said, okay, you can stop right there. Stop. And they said, you want us to continue? He said, no, the maximum dose is where I want her. And I thought that was so funny that, and I thought about those smart pumps, and I kept thinking, that's one of the problems with the smart pumps and having family right there is they don't understand. They only know what they see, and then they get on their smartphones and they don't understand what they're looking at when it says the maximum dose should be this many mics, and they don't understand what they're doing. So I think it's interesting when you get families involved. So I think it's interesting. So I don't remember what your question was, but the question is, you got to look at the patient, and then we got to look at what's the norm. What are we actually trying to do? But you'll have orders for it. You'll have orders to titrate to keep patients' blood pressure greater than X.
Yeah, that's all.
We never got her above 70, but okay. But that's what you'll have. You'll have a titration type thing. And that's what it'll be. Is how it'll work. That's how it'll work. Okay.
Jenny, I have a quick question about trach patients.
Sure.
So if you have a patient who's trached in on a vent and they dislodge their trach and you need to use an ambu bag to supplement oxygen, are you going to plug their trach somehow using a mask over their patient?
What do you mean by dislodge their trach? I don't know if I understand.
Like say they've like pulled their trach out.
If they pull their trach out, you can't breathe through the stoma. The ambu bag will not breathe through the stoma. So you've got to put the trach back in. The best case scenario is you have a clean trach right there. And the unit probably does have a trach right there. If not, grab the one they pulled out at the head of the bed. I don't know if you've ever paid attention to it, but when they pull the trach, when they put the trach in originally, there will be a baggie there, and there will be a little thing that looks like, I have to see my face to see if y'all can see this or not. There'll be a little baggie that has something that looks like this in it. Almost looks like a little penis looking thing. The end of it looks like this. This is called an obturator. Okay. And it's very smooth. This is a very smooth piece right here. Very, very smooth. And if they cough out their trach, and they're going to do it because somebody took the trach ties off, or they pulled up the things off and didn't put the new ones on right. You take this and you put it, you pull the cannula out. It won't work with a cannula. You have to take the cannula out. It will not work with the cannula in there. Okay, it will not. You got to pull the cannula out. Slide your obturator in. Whoops. Slide your obturator. I'm not worried about sterility at this point. This person's losing their airway. Okay. Slide your obturator in. Put your finger on it, kind of like a syringe would be. Now the end of it is that it's really smooth now. Very, very smooth. And simply slide it right back in. Pull your obturator out, and now I've got an airway. And then I can be hollering for help. Somebody bring me some trach ties and just put it in there and tie it back down. Now it's occluded until you get the obturator out. But this is really hard to put this in if it's not smooth. And so the obturator smooths it out and slides it in really easy. But when this trach was originally put in, there's a baggie inside that box, and the obturator is put inside that baggie, and the baggie is taped to the head of the bed so that the operator is stuck at the head of the patient's bed. So in case you need it quick, you can just stick it right back inside that trach and stick it right back in. You probably never noticed that before.
No, that's amazing. I have one of those in here and I thought it was garbage.
It should be at the head of the patient's bed. Got an operator. Learn something new every day.
Yeah, I just wasn't sure how you handle that situation because I was in a room one time and there was a nurse who had never dealt with a patient on a ventilator before. And another one had asked her like what she would do if he were to like pull his trach out and lose his airway. And she had talked about like plugging his ostomy and using a bag valve over his face.
Well,
like she was like, you're literally just going to take 2 fingers and put it over his ostomy and then start with an ambu bag.
I would not do it that way because you probably can't plug their ostomy that way if you want to know the truth. They're going to breathe around it, or you might be able to do it that way. I would not stick his trach back in. I've had to stick the trach back in if you want to know the truth. Just once in my career. And I have I'm an old woman. You could, but it's really hard. I don't know that you would be able to breathe for them very well. If I had a Vaseline gauze in there, which I'm not sure that I would, you could take a Vaseline gauze and slap it over there and it would probably work. Because Vaseline gauze would be impermeable and they wouldn't be able to breathe through it. But that would never come to me as an answer. I would stick the trach back down. That's what I would do.
Yeah, I mean, that's what I
guess the answer would be fine, but man, I got news for you. I can't hold that trach closed. And I cannot hold that closed with one hand, put an ambu bag, get a seal around their mouth with one hand and compress the bag by myself with one hand. I can't, it's physically impossible for me to do. So I think that answer sounds like a good answer, but in practicality, you couldn't do it because I would have to release this trach in order to put that down, and bag valve mask takes 2 hands.
Yeah, that's kind of what I was wondering too, is how they would be able to do that by themselves anyways.
Couldn't
but
do
I
it.
work in peds, so I didn't know if it was different in peds because the patients are smaller, but.
I still don't think you could do it. Now, maybe be in peds if it was an infant. I still don't think I could do it. Because I have got to open their airway. I've got to use one hand here. I've got to use the other one here. I can't open their airway and compress the bag with one hand and hold the trach with the other one. I can't do it. I physically can't do it.
Makes sense.
I don't think I can do it. I can put the trach back in, hold the trach with, if I don't have trach ties, hold the trach with one hand, hook the ambu bag on it and bag with one hand. I can do that. Yeah, I think in practicality, it sounds like a good answer, but I think in actuality, I don't think you could do it. I don't think you could do it. And I've bagged many of people. It's hard. Bagging people's hard. It's harder than those mannequins. A bag valve mask on a person, getting that neck back and bagging somebody is tough. It really is. It's very hard. Now, once you paralyze them, it's not hard. It's easy. But somebody that I had a student one time in the ER. I used to take a clinical group to the ER, and he was going to go to the bathroom, and he was walking past now it's a X-ray department, but it used to be a waiting room back there. And he was walking to the bathroom, and he came upon a patient dead in the waiting room. And so he grabbed the patient to the floor and started CPR in the floor and was hollering for help. And he saved the guy. He actually had a dissecting aneurysm, and he saved the guy's life. And later they were asking him what was the hard, because he'd never started CPR on anybody. And he said, what's the hardest part? Because the absolute hardest part was open, and he was doing mouth to mouth. He didn't have an ambu bag. He said the absolute hardest part was opening the airway and trying to get air in that guy. He said that was the absolute hardest part. And I said, you're exactly right. That is the hardest part. It's getting air in that person. It's tough. It's really hard. All right. Any other questions? No? Okay. I'll see y'all back here at noon. I mean, I'll probably come back in here and sit in just a minute. So if anybody has questions, I don't mind answering. Okay.
Thank you.
I will say those dissections are really bad.
That what?
Those dissections are really bad. We had
Oh,
one
good
like
God,
2 months
yeah.
ago. I work at the ED in Pine Bowl, and
it-
we had one in one of our small rooms, and we coded this man for an hour and a half because he was 37.
Mm-hmm. Oh,
But
wow.
he-
Did he
yeah,
dissect
no.
it? That's unusual.
He blew out his aorta. It dissected upwards into the heart instead of downwards.
Oh,
And
wow. That's
so
very,
when
that's very,
we started
bad.
compressions, and like the cardiothoracic surgeon came from Maine, and he was like, "Nope, there's nothing we can do. Sorry."
oh, I believe
And
it. You know, I used to work, when I first got out of nursing school in Kentucky, I worked on it. Well, I worked on a big unit. I mean, it was huge. It had 135 beds. And we did cardiothoracics, vascular, plastics, general surgery, urology, and ophthalmology. Now get that. And it had a 12-bed septic ICU and an 8-bed burn unit. That was what was on this unit. And then I became the nurse manager of this unit. So, and so I had when I talk about the experience that I had, it was all the same unit. So I had a lot of different kinds of experiences, but I'll never forget, I had a cardiothoracic surgeon who was sitting on the patient's bedside, and he said, "You understand, the patient really didn't want to have surgery, didn't want to have his aneurysm fixed, his AAA fixed." He said, "If you blow right this second and the nurse hands me a scalpel, I will not be able to save your life right now. If I'm sitting right beside you when you blow, you will die. I cut you right here, you will die." Now, dissection, you might get to them if they're dissecting. You might, because they're going to, it's the layers that are dissecting, so they don't blow out.
Yeah.
But, so you might be able to save them if they're dissecting. But if they blow, you can't save them. You'll never save them.
This particular guy knew he had an aneurysm. He had chest pain for 2 days. He sat out in our waiting room for 2 hours. We brought him back.
Don't you love it when they sit in the waiting room?
Like an hour later, they were reading him his results, and his eyes rolled back in his head, and he was gone.
Oh, I know. It's so awful.
Cool.
So awful. When that
That
happens,
one,
it really is.
That one's rough.
It's not good. It's bad. So it's interesting. There's always the bad. I mean, you always remember the bad ones, or the ones that maybe could have been handled a little bit different. I don't know. In my career, I remember the bad ones that maybe could have been different. But you remember the good ones sometimes too. And the good things. I don't know. All right, I'm gonna run out here for a few minutes. Y'all take care. I'll be back. All right.
Thank you.